and heartfelt gratitude to Dr. Banshi Sabu. Dr. Joshi called him brother. I'll have to call him elder brother because of the sheer experience, not just the age that he possesses. He's the torchbearer of care. Yeah, and has special interest for children and adolescents with type 1 diabetes. So I'm going to speak on the little work on automated insulin delivery that we've done and how it could act as a milestone on the road to insulin independence for children and adolescents with type 1 diabetes. Now, clinicians and researchers have envisaged either technology or biology as the road to insulin independence for patients with type 1 diabetes. So we have two concomitant arms, both complementary to each other. And in the technology arm, the current is currently represented by automated insulin delivery or advanced hybrid closed loop devices. And we look forward to fully closed loop devices or multi-hormone closed loop devices becoming a reality in the near future. And if we look at the biologic arm, it's pluripotent derived stem cell, pluripotent stem cell derived islet transplantation with glucocorticoid-free immunosuppression, which represents the biologic arm. And what we need to look at is ways to avoid immunosuppression by either macro-micro encapsulation, gene editing, or then look for patient-friendly immunosuppression. So this is what the world is envisaging, and Dr. Banshi asked me to have a word on history before getting on with the presentation. So I'd like to call these days, I'm not being ungrateful for the discovery of insulin. It was a game and a life changer, but these were the bad old days of diabetes mellitus where we only had insulins with variable and unpredictable action profile, lack of knowledge about intensive glucose monitoring, and neither did we have metrics to define appropriateness of monitoring, and neither did we have knowledge about intensive insulin therapy. So this era was always characterized by very high blood sugar readings, poorer glycosylated hemoglobins wherever it was possible, high incidence of microvascular complications, and shortened lifespans for patients with type 1 diabetes. Then came data emanating from the landmark DCCT study, which said that all patients with insulin-dependent diabetes mellitus must be on closely monitored intensive insulin therapy, which actually revolutionized management of type 1 diabetes, and the goal was to achieve near normal glycemic status. Now, before we talk of the need of automated insulin delivery, let me show you some global data, observational analysis actually, of glycemic control, hypoglycemia, and management metrics of patients with type 1 diabetes. I'll begin with the SAD study, and to our horror, if you look, only 21% patients from Asia are able to achieve a glycosylated hemoglobin of less than 7 amongst type 1 diabetes. If you dissect the data further, you'll realize that insulin initiation is often patient driven, but eventually over years, insulin therapy becomes physician driven and does not take into account pre-meal sugars or the carbohydrates being consumed. This is data collated from centers where there is data maintained. You can only imagine in a country like ours, where data is not maintained across multiple centers, the picture could be far poorer. And this is not just Asia. This is data from one of the better diabetes centers in Denmark. And you can see at the best of the centers, multiple daily dose infusions and non-sensor augmented pumps provide a time in range of nearly 50%, and it was very clear that addition of continuous glucose monitoring systems started to optimize glycemic control until automated insulin delivery devices came into the picture where international consensus goals could be met. So this is again a cross-sectional comparison, but it's for you to view and understand that it's continuous glucose monitoring and covering up for inefficiencies of the physician and the patient that enabled, or rather enables, these children and adolescents and even adults with type 1 diabetes to attain international consensus goals. So why is all the fuss, or what is all the fuss about? The most difficult part of managing type 1 diabetes is the prandial doses. The basal insulin is regulated by the physician, but prandial doses are difficult for patients to manage on a day-to-day basis. This is how each bolus, each day, each time, for every carbohydrate consumed, whether it's a meal or a mid snack, needs to be calculated. It's the food bolus, add to it the correction bolus for a reading above 120 milligrams per deciliter, subtract the insulin on board, which is very difficult to gauge and estimate each time, gives you the correct bolus. And let me tell you, all day, every day, each meal is a struggle. 76% of the patients in India feel carbohydrate counting is a burdensome activity. 2/3 underestimate carbohydrates, and 50% of the postdoctoral fellows try to skip learning carbohydrate counting. That's the scenario in a tertiary care institute like mine, so you can only imagine what happens in the rest of the country. And this is what is supposed to guide insulin delivery for patients with type 1 diabetes mellitus. These are numbers from across the world. 1 out of 3 high prandial readings are not followed by a correction bolus, and wherever the patient makes an endeavor to correct, 50% of the times the bolus calculation is inappropriate. This is what lets us understand the need for an algorithm to calculate and deliver boluses. Why do we fear hyperglycemia in the current era, especially in children and young adults? Diagnosis of type 1 diabetes prior to the age of 10 years results in a median loss of life of about 14 years for men and 17 years for women. Hyperglycemia is associated with cognitive impairment and brain damage. Acute and chronic hyperglycemia impairs spatial working memory. So these are the take home or the driving home messages. This is the data to support these statements. I'm showing you the impact of type 1 diabetes on the young brain, a longitudinal study. And if you look at it carefully, higher sensor glucose readings, higher HbA1cs correlate inversely to full-scale IQ, not to mention the specific learning domains, and also to total brain volumes right up to 12 years of age. So patients who have poorer glycemic control have relatively smaller brain volumes and also have impaired cognitive scores. Now, time in range is the current glycemic metric. It's the percentage of the day spent between readings of 70 to 180 milligrams per deciliter. Glucose management indicator while using technology is a reflection of average short-term glycemic control. These are the two current era metrics to be used by clinicians while dealing with technology-driven insulin delivery. And the goal is to achieve a minimum of 70% of the day being spent in range, and to allow hypoglycemic episodes to be less than 4% of the day. These are the current goals or standards in glycemic control for patients with type 1 diabetes. This is how technology evolved. A brief timeline: 1920 was when insulin was discovered. The first commercial subcutaneous insulin pump became available to us in 1960s. And in 2020, through a series of evolutions, the advanced hybrid closed loop device saw the light of the day. Quick terminologies before I move. The hybrid closed loop device regulates basal insulin secretion based on sensor glucose every 5 minutes. And what is the advanced version? It also offers auto correction once the basal rates have reached its Umax or saturated value. So the difference between hybrid closed loop and advanced hybrid closed loop is the ability to provide auto corrections. This is how the system looks. Sensor glucose data is relayed to an algorithm which then determines the dose and allows the insulin pump to deliver insulin. Now look what the world says. The American Association of Clinical Endocrinologists in 2014 used to say that automated insulin delivery systems must be reserved for patients motivated to achieve optimal blood glucose control. Whereas in 2025, its practice statement clearly mentions that automated insulin delivery should be the preferred modality of insulin delivery for patients with type 1 diabetes. It is supported by the ISPAD that AID systems are strongly recommended for preschool children, school-going children, adolescents, and young adults, practically everyone whom a pediatric endocrinologist sees, to optimize glycemic metrics, minimize excursions, and improve patient-reported outcomes and reduce burden of care and distress. They're also recommended for newly diagnosed patients. There was a word of reservation initially that some time must be allowed after the diagnosis is made before these systems are introduced. But in the last statement in 2024, a recommendation has been made to consider early introduction based on the social circumstances, preferences, and the needs of the patient. So the types of AID systems, I'm not going to go into detail, but what we need to understand is we have a principal integral derivative algorithm available in our country. The model predictive control algorithm, which are the other 4 types of systems, are not yet available in India. What do I mean by principal integral derivative? Principal is how deviant is the sensor glucose value. Integral is how long has it been deviant. And derivative is the rate of change of sensor glucose. So the algorithm senses 3 parameters and decides what insulin must be administered to the patient. So the system is approved for use above 7 years of age, but we are using it in younger patients whose total daily dose requirement is at least more than 5 units. So any patient who requires 5 units or more could be offered the option of automated insulin delivery. The key features are regulation of basal insulin every 5 minutes based on the target offered to the system. You could offer a target of 100, 110, 120. And once the basal delivery is saturated, an autocorrection can be delivered every 5 minutes to optimize the blood glucose. There is also a safety feature which prevents hypoglycemia because it just does not do an arithmetic but simulates and projects the sugar in the ensuing 4 hours, looks at the CGM data over the last 12 hours, and then mitigates the bolus to be administered. So it's a very robust algorithm, and the incidences of hypoglycemia are negligible. This is how the typical sensor glucose data looks, and the metrics that the clinician handles is the basal target that we offer to the system, the active insulin time, which varies between 2 to 6 hours, and the optimal setting to be provided to children is around 2 or 2.5 hours to begin with, and the insulin carbohydrate ratio based on the total daily dose. What the patient needs to do is count carbohydrates accurately, enter carbohydrates at least 10 minutes before the meal, and not skip or delay the bolus doses. These are the things which are clinician driven and user driven. Every visit, these need to be reaffirmed to the patients. And what you need to do as a back check is look at the total daily dose and partition the insulin delivery into user driven, which is the patient, versus system driven, which is the algorithm. And every visit, try to convince the patient to keep the reliance or dependence on the system to 50% or lesser. That optimizes the glycemic control. Though these devices are automated, the endeavor is always to empower your patient to enable near equal insulin delivery to avoid errors. So this is just a meta-analysis of about 25 RCTs which unequivocally stated that these systems are more effective than conventional insulin therapy for children and adolescents with type 1 diabetes in the outpatient setting. And the favorable effects are consistent not only in the short term, but also on long-term follow-ups. Now I'll show you some quick real-world evidence, because there's often variance in data to the tune of 25% between controlled trials and in the home setting. I'll show you some European data of about 3,000 pediatric users of AID systems, and you could see that the mean time in range was about 74%. whilst maintaining the international consensus goals of having hypoglycemia less than 4% of the day. And when the settings were optimized, which means a basal target of 110 milligrams and an active insulin time of 2 hours was provided, you can see the mean time in range went up to 77% without a significant change in the time below range or the incidence of hypoglycemia. Now this is data from our country, which is perceived as the third world. My team, my group studied the sensor glucose data of 160 of our patients, and the mean time in range of our group was not very different from the European cohort. Ours was a retrospective study from 10 centers across the country, and you can see closely that not many centers in our country were providing optimal settings. You can see the difference. Optimal settings were provided to 35% across European centers and only to 3.6% in the Indian setting. The action had already occurred before data was analyzed, but in spite of that, 71% was the mean time in range of the group, and nearly 57% of our patients were able to attain the international consensus goals. This was 2023 when we presented this data at the SPAD Netherlands, and we've made significant strides from there. And I'm happy to say that nearly 74% of our patients who use optimal settings and adhere to appropriate user behavior are able to easily attain the international consensus goals. I'm not going to go into detail, but the RCTs for patients between 2 to 6 years also demonstrate similar effects, with about 10% increase in time in range and time in tight range, and a 0.6% reduction in the HbA1c with no severe hypo or hyperglycemic events during the control trial. So it's not far when these systems will receive FDA approval for children between 2 to 6 years of age. Now, factors that clinicians must know which are associated with improved glycemic control metrics while using automated insulin delivery systems is high usage or appropriate usage. Your patient must use the sensor and the smart card for 85% of the time or more. This, with a better algorithm which is available now, like sensor-driven basal rates, automated bolus corrections, increased time of exit from automation, and increased time of Umax and Umin delivery ensures optimal glycemic control. What clinicians could do is provide optimal settings, provide them correct basal targets to be achieved, set the active insulin time or duration of insulin action to 2 hours, reaffirm appropriate dosing behavior, appropriate carbohydrate counting skills, assess partitioned insulin delivery into basal versus bolus, user versus system driven during each clinical visit, and revise the insulin carbohydrate ratio based on the total daily dose and the prandial excursion seen. Most importantly, multidisciplinary supervision, support, because you're dealing with children, so parents require immense support, and a structured training initiation program add to the success rates of these systems. Now, a last slide before I conclude is a word on stem cell derived fully differentiated islets for type 1 diabetes. Where are we currently? So I'm going to present some data on the phase 1-2 study published in the NEJM as recently as June this year. And a full quantum of these pluripotent stem cell derived allogenic islets were infused to 12 patients via the portal vein, followed by glucocorticoid-free immunosuppression. Engraftment of islet cell and islet cell functioning was documented by detection of C-peptide during a 4-hour mixed meal tolerance test. The metrics that were tested is freedom from severe hypoglycemic events between day 90 and 365, that is between the 3rd month to a year after having received the infusion, a glycated hemoglobin of less than 7, and a decrease in the glycated hemoglobin by at least 1% from the baseline. And To our pleasant, not surprisingly, 100% of the patients were able to achieve this metric. Insulin independence at the end of 1 year was achieved in 83% of the patients, but the deterrences were severe neutropenia in a fourth of patients and death due to opportunistic infections and aggravation of pre-existing dementia in 16% of the patients. So my key message is, our AID systems are more effective than conventional insulin delivery systems for children and adolescents with type 1 diabetes. The favorable effect is consistent both in the short and long term. Number of AID users attain the international consensus goals by improved appropriate usage, provision of optimal settings, ongoing education regarding user behavior, supervision, and a structured initiation program. Stem cell-derived therapies may represent the future biologic cure, but challenges remain immune rejection, cost, and scalability. Both technology and biological approaches seem significant milestones towards insulin independence. And before you all leave, I'm going to leave you with 4 thoughts to resonate when you go to bed tonight. 1, access to technology is not a luxury in type 1 diabetes patients, but is an essentiality. The best way to predict the future for children with diabetes, with type 1 diabetes, is to create it. The road to insulin independence is not just about technology or biology, but is about hope, equity, and future, where every child with type 1 diabetes can dream freely. And lastly, India ratified the UN Convention of Rights of the Child, Article 24, way back in 1992, which stated that state parties must recognize the right of a child to attain the best standards of health and seek treatment for diseases and rehabilitation of health. But are we doing enough for them is for you to decide. Thank you, ladies and gentlemen, for the patient hearing.
Thank you, Abhishek.